Good evening, pharmacology friends. We are going to talk in this lecture about unipolar depression. After that, we'll have another lecture about bipolar medications, antipsychotics. We'll see that there is quite a large overlap between the two of them. But right now, let's talk about antidepressants. And I just love this picture of a sun and clouds made out of pills. It's so wonderful to me, warms my heart as a pharmacologist. Before we talk about drugs for depression, it's important to talk about the physiology, the neurophysiology especially. You know Dr. B's rules. If you've watched my videos before, heard my lectures, if you understand the physiology, the pathophysiology of the diseases, then you don't have to memorize anything for medications. It will all come easily if you put your time into understanding the physiology. So first we'll talk about the clinical aspects of depression, how to recognize it, what the prevalence is in society. We'll talk about some theories underlying depressive symptoms, and then we'll get into the three major classes of antidepressants: SSRIs, tricyclics, and monoamine oxidase inhibitors. We'll understand the risks and benefits of treating depression, and then we'll look at some really interesting data on alternative ways to treat depression with some newer therapies like transcranial magnetic stimulation. Really cool stuff. Um, there was a really troubling study that came out, at least it troubled me a while ago, that stated that 1 in 10 US adults reported depressive symptoms. When we look at the prevalence across all US adults, the lifetime prevalence is about 16.5%. So that's almost 20% of the US adult population at some point in time has had depressive symptoms. The 12-month prevalence, meaning the last year, if somebody as an adult experienced depressive symptoms, now our levels are about 7%, with really severe classifications in the last 12 months, about 2% of the adult population. The latest study that I mentioned was troubling to me is that 1 in 10 of adults in the United States report depression. And that makes me really sad. And that also leads me to want to talk to you about why these drugs don't have the best side effect profile or also therapeutic profile. So perhaps when we get to the alternative treatments, we can make some recommendations that perhaps don't have to do with these classical types of medications. But yeah, 1 in 10 of people in the adult range of the United States are taking these. What that also means is if you're not prescribing these medications and it's just a patient of yours that you're seeing for other reasons, it's important to be familiar with these drugs because they are so prevalent. Yeah, so more than 1 in 10 people, they take antidepressants. The latest estimate was about 30 million people in the United States are taking active antidepressant therapy. The most commonly cited age group is women age 45 to 60, which is in the normal age categorization of general women seeking care. So the trajectory of something means how it goes. Does it stop? Does it keep going? So with an episodic disorder, so like an episode of depression, it can follow a chronic course, but usually you see just an episodic disorder where it's a period of depression that is sometimes linked to an event, a life change. But in 20% of cases, it does follow a chronic course without remission, meaning it doesn't get better. And the recurrence rates from the first episode of a depressive incident are 35% recurrence within 2 years. And then once you go out to 12 years, it's a 60% recurrence rate. So that means not only are we going to deal with people taking these medications, but we also have to plan that they're probably going to have symptoms again later on and need to be on medications again. The other troubling thing that I want to definitely keep in the back of your mind is that 15 to 20% of patients do choose to take their own life, which is essentially a brain killing itself, a brain deciding that it's time for it to die. And we do see that rates of suicide in certain populations go down with pharmacotherapy, Unfortunately, in adolescent populations, there is some evidence that suggests that rates of suicide go up with pharmacotherapy. Because so many people are taking these drugs, we used to see things like Lipitor as number one of the money makers in the pharmaceutical industry. Now we're starting to see in the top 15 antidepressants, and this is a very atypical one, Cymbalta. It's starting to climb up, and Abilify is another one, to these really high um, grossing drug prices. So out of the 15 top grossing drugs in the United States, we see two of these antidepressants now on the list. In 2012 alone, Cymbalta, which is this drug at number 13, made almost $5 billion. So that's not of all time, that's in that year. That's how much sales of that drug grossed. So these are really, really prevalent medications, and they are a large source of revenue for the companies that produce them. This is a listing of the DSM-5 symptoms for depressive episodes and depression. There are some shorter screens that I will put up on the Canvas page to help get to these. There's really long questionnaires. They're called like the SCID. There's an abbreviated one, and then there's the full one, but it involves some questions about depressed mood and other mood symptoms. So the typical symptoms we associate with depression: depressed mood most of the day, it's usually nearly every day, feeling worthless, excessive inappropriate guilt, recurrent thoughts of death, suicide, anhedonia. Hedonic means bringing pleasure, so an means without pleasure. So the things that once brought somebody pleasure or enjoyment are now gone. So they might give up hobbies or hanging out with the people they normally did, avoiding interactions, avoiding family, and then not deriving pleasure from the things that once gave them pleasure. Because this is a serotonin related disorder, so 5-HT, 5-hydroxytryptophan is how we'll abbreviate serotonin. We can see things kind of swing both ways depending on what's going on with that individual serotonin-wise. And serotonin mediates things like sleep and appetite. So you can either see people having an increase or decrease in appetite, increase or decrease in sleeping, and then same thing with muscle movement. They can either show psychomotor agitation, where there's a lot of movement. There can be some tremoring, things like tapping your finger, shaking your foot, or slowness of movement. Fatigue, indecisiveness, diminished ability to concentrate, which is why you'll see not only will these targets be looking at serotonin effect, they're also going to, in some cases, affect norepinephrine. Because the more norepinephrine you have, the more ability the prefrontal cortex has, the PFC, in making decisions and concentration facilitation. Because serotonin and norepinephrine, they're not just in your brain, they're all over your body. You also see physical symptoms when there's alterations to these, and you also see dopamine in there too, DA. Anorexia, an means without, and orexia is referring to orexin, which is a neurotransmitter associated with making you feel hungry. So anorexia means without orexin activity. So you don't ever get the signal that you need to be food seeking. And depending on the amount of anorexia, there can either be weight loss or weight gain. GI disturbances. Serotonin is really important for vasodilation in the GI tract. So when serotonin's around, it dilates blood vessels so that there's increased activity in different areas. If there are low levels of serotonin, that might mean that there's decreased dilation, decreased blood flow to the GI tract, so you'll have slowing of digestion. Or if there's more alterations to like dopamine, you can have more diarrhea. Disruption of circadian rhythms, and you need to sleep at appropriate times in order for the different hormones to spike at the appropriate times. And if they're not doing that appropriately in a circadian fashion, you can have endocrine homeostatic disruption. Another homeostatic thing tied to circadian rhythm is body temperature, because your body temperature is very low during the night and then it spikes throughout the day and then it goes down again. So if you're not sleeping, you're going to have all these alterations to body temperature. So it is going to involve somatic, soma means body, so somatic symptoms as well. It's not just brain, serotonin, norepinephrine, dopamine, epinephrine. These are all catecholamines. Serotonin is an indolamine. And indolamines, there's serotonin and then there's melatonin. So these things are going to affect pleasure. So dopamine is like your pleasure one. Boop. There we go. Serotonin is appetite. It's sleep. Melatonin is sleep. Serotonin is muscle. It's GI. So we see that just slight alterations to these things, they're really going to cause a sequela of effects. So when people meet different, it's usually like 5 of these categories, then you would see a diagnosis of depression. Okay, so then just going through the different types of depression, there is reactive. Reactive is when something really crappy happens and you feel depressed. That's a normal reaction, right? Like when something really crappy happens, you would expect that you feel depressed. You have feelings, you're a human, but that doesn't always mean that they're in the right severity. So reactive depression, you can see people develop major depressive episodes when they're feeling really sad, when something really disrupting happens in their life and they have a predisposition to depression. And then there's endogenous depression, meaning it's generated from within. There is no specific like situational generator for these mood alterations. It's just something that derived from that person. What we're talking about in this lecture is unipolar depression, meaning we're just dealing with from the poles going from depressed to manic. Unipolar means it's only manic, one pole, whereas bipolar is both of them. So you're going to see depression and mania. So unipolar is just one, just depression, and it can either be retarded depression, meaning there's psychomotor retardation, so people slow down, they have anhedonia, a little reaction to the environment, they're sleeping more, they're not eating as much, they're avoiding social situations. Where agitated depression, that's when people start tasks and they don't finish them. They lose their train of thought very easily because they're having difficulty concentrating. But there is like an alteration to the amount of psychomotor activity they have. So they're doing a lot of activity, but not necessarily accomplishing much. Bipolar depression we'll talk about in the next lecture. So there's bipolar 1 and bipolar 2. They're going to fall into their own class. And then we have to figure out if this is a depressive episode versus a chronic or even a long-standing depressive disorder. And that will guide its medication, pharmacotherapy. Okay, so the cause, etiology of depression. There are a few theories in the science world about why individuals experience depression. And the one that pharmacotherapy is based on is called the biogenic amine theory. And as I mentioned before, that refers to alterations in the amines. So we have catecholamines, that involves dopamine, epinephrine, and norepinephrine. And again, the indolamines are your serotonin and your melatonin. So the idea is that when you see low levels or disruptions to these classes of amines, then that is going to cause homeostatic and physiologic disruption to neuroactivity and then also somatic activity. So all of the current pharmacotherapies are based upon restoring levels of these catecholamine, indolamine, so that they can regain natural function. There's the HPA stress theory. The HPA axis is hypothalamic, pituitary adrenal axis. So that involves a lot of cortisol production, having to do with a lot of physiologic or psychological stress. So when the HPA system is overreactive and dysregulated, the theory is that excessive cortisol, excessive HPA axis activity leads to depression. There's a ton of research into that. And some of it is very holistic, so it involves biofeedback training, relaxation, things of that nature. And then there's the neurogenic theory, which is a newer one, which states that stress produces deficiencies in growth factors and neurogenesis. So one of the markers that there's new neurons being grown is called BDNF, brain-derived neurotrophic factor. Do you remember in school when you learned that you're born with a certain amount of neurons, and once they die, then they go away forever and they never come back? Well, guess what? That's not true, and that's good news for all of us. And we can tell when there's new neurogenesis going on by looking at levels of BDNF. So a lot of these newer treatments are targeted on finding this specific growth factor, which drives neurogenesis, so that if you have more levels of the growth factors, then you won't have the alterations and abnormalities in neuronal function that you see in depressive state individuals. So how do we develop drugs? This is called behavioral pharmacology. And you also have to remember that when we do studies with mice or with dogs or with cats, they're not just little people. They have the same brain structures as us, but when we excite pathways, the activity that, or the behavior that a person or a human would exhibit are different than the behavior that a mouse, for example, would exhibit. So one of the things that we see indicative of like depressive or anhedonic symptoms in a mouse is when they stop swimming in what's called a forced swim test. I don't know if you've ever seen mice swim, but they're really fast. They're really good at it. They swim really quickly. They're great swimmers. And if you put like a normotypical, neurotypical mouse into anything with water in it, they're going to swim, and they swim for a long time. And that's what you would expect them to do, even when they can't get out of something like a glass barrier. And then when they feel like they can't get out, they still continue to try to climb up the wall. Eventually they give up like a person does, and you just kind of float for a while, and it's like a defeat model, like, all right, well, that's not going to work. I might as well just conserve my energy and float here and relax. What we see is that anhedonic mice with genetic alterations to them, to exhibit anhedonia, they are faster to float in a forced swim paradigm. What we see is that when we give drugs that are used for depression, it prolongs the amount of time that they swim for, which would mean you can make them seem human if you want to. I don't want you to do that necessarily, but it's like they're not giving up as soon. They try harder to swim. And this, I mean, they're taken out after this. They're not put in here and drowned. You see how long it takes for them to float, and it's called latency to float. So we consider a drug a good candidate for an antidepressant when it increases the latency to float, meaning that it increases the time for a mouse to go from swimming to just floating. Okay, and then there is a similar type of paradigm where it's looking at chronic stress and also defeat. So this is a barrier study. So there is an electrified part of the floor, and then there's a non-electrified part of the floor. What the animals, and they do this with people too, it's pretty funny, there's a light that comes on. It's called a pre-pulse tone or a pre-pulse light. It's a stimuli that teaches them, it goes on right before the floor is going to be electrified. So it's just like a little jolt. And if they come over here, then they're going to be safe. And they learn that really quickly. You know, like you shock your feet, and you're like, ouch, I'll go over here. Oh, it doesn't hurt. How nice. When there is anhedonia in animals or in people, what you find is that they don't even do that after a while. They'd rather just stay here and be electrified, and they don't even try to move over there, even though it's right there, and all they have to do is step over this tiny little barrier. We consider drugs good candidates when they encourage the animals to actually go over there. So when they don't, we call that learned defeat. Like, who cares? I might as well just stay here and be shocked forever. What does it matter? Nobody cares anyway. So when we can improve that with medications, we see that we have animals and humans escaping something that would be negative to them. So that's the way these drugs are first developed, is using these simple tests that are, again, affecting brain areas and neurotransmitters that are consistent between animals and humans, but they don't elicit the same behavioral response. Okay, so the final intro with the drugs and how they're going to interact with the physiology. As I mentioned before, the amine system and these drugs are going to target some very large neurotransmitter systems, the primary of which, especially thinking of lay purposes, is serotonin. And serotonin is a major neurotransmitter. The nuclei that create serotonin in the brain are called the raphe nuclei. So they're interwoven throughout these hindbrain regions. And there's some that goes down the cord because serotonin is important in the anti-pain or analgesic response. And the rest of the serotonin goes throughout these neural tracts in the brain. So to thalamic areas, and your hypothalamus, that's your homeostatic center. So serotonin is really important in homeostatic regulation, like sleep. I mentioned it's really important in pain regulation. So nociception is pain reception. Basal ganglia is movement. Your thalamus is also going to be homeostatic regulatory properties. Your neocortex, that's what you think with up here. So decision making, concentration. So when there's low serotonin, like we see in depressive or anhedonic states, you see alterations to all of these things that serotonin facilitates. So drugs that alter serotonin will alter mood. The hypothesis between serotonin and anhedonia, or lack of pleasure, in animals and people states that low serotonin is driving, or at least a familiar pattern, with anhedonia. Again, norepinephrine, it is a really important, really important neurotransmitter. It's one of the catecholamines. It goes all over the body. This is the locus ceruleus. This is one of the places that we're going to see branching from. The NTS, nucleus tractus solitarius, that's the main nuclei that integrates feeding information. I'm getting tired. So here we've got our NTS, we've got the raphe, locus ceruleus. These are all places that are associated with the production of norepinephrine. And that has effects on, again, the thalamus, our homeostatic centers, the hippocampus, that's a memory integration center. And you should remember that because the hippo looks like an elephant, and elephants never forget. Thalamus and hypothalamus, again, homeostatic. And then we have the rest of the norepinephrine coming out to the prefrontal cortex and other cortical regions, like right around here is where we start to get into motor pathways. So norepinephrine is really important for modulating alertness and arousal so that you can wake up and feel like you're awake in the morning. That's really important. Your heart rate, because norepinephrine is released from nerve terminals to bind to the myocardial cells so that they beat. And then because it sets your alertness levels, it's also important for sleep, feeling awake, for learning, and for memory, which is associated with this over here, the hippocampus. So your hippocampus integrates memories, and then those memories are stored up in the cortical regions. Okay, finally, we've got my favorite, we've got dopamine. And dopamine, we definitely know from studies in animals and people that levels of dopamine are prevalent in individuals with depression. Dopamine is released from two separate bodies. One is called the ventral tegmental area. We'll talk about that more later. And the other one is the substantia nigra, SN. That's the one associated with Parkinson's disease. So when there's a lot of dopamine neurons here, there's no Parkinsonian symptoms. When they start to die, you get Parkinsonian symptoms. The ventral tegmental pathway. This leads to the nucleus accumbens and then different prefrontal networks. That's what leads to motivation, reward. You eat a brownie and then you feel good. That's that pathway. Where the substantia nigra pathway goes to some motor centers and midbrain regions too, and then eventually cortical. So it's important for, again, motor control, like we see in Parkinson's, reward, like what's going here, in the nucleus accumbens and prefrontal regions. It's also really important in prolactin. You need to have dopamine activity for active prolactin release and lactation. And it's also really important in the retina, meaning that's where your rods and cones are, so that you can see things in color as well in black and white. Okay, so should you consider pharmacotherapy for a patient? When the intensity of their symptoms interfere with the daily routine is one of the most important rule of thumb. If they're no longer waking up on time, grooming in the way that they typically would, not engaging in activities, taking more days off of work, that's definitely a time to come in with pharmacotherapy. When it is not just an episode, so it's not just a couple of weeks feeling really crummy or worthless or wishing they were dead, but when it's starting to last months, if there's suicidal thoughts, and it becomes really, really, really important for a recommendation to be made, not only when there's suicidal thoughts, but especially when there's a plan. So if somebody reports feeling like they'd be better off dead, if they were to be asked, have you ever thought about how, and they have a plan, that's the time where you really want to refer them, not just for medication, but also possibly inpatient treatment if you feel that they're a danger to themselves at that time. BP is bipolar disorder. If you consider that it's bipolar, that is definitely a time when medication should be considered rather than an alternative therapy. Okay, general guidelines. The efficacy is similar between the medications, meaning that they're shown to work at about the same level in relieving depressive symptoms. Because the recurrence rate is so high between depressive episodes, usually what you ask is, well, what did you take before? Did it work for you or not? That will guide the first choice. So if they've already been on something and it worked really well, then you might start with that. If it didn't work for them and they're having depressive symptoms again, you probably want to try a different drug class. And also the side effect profile. Because they all have the same efficacy, you can look at the amount of side effects. Some of these drugs have really severe side effects, and some of them have minimal. So that's a pretty good way to pick a drug. Any coexisting conditions, some of these are really going to affect cardiovascular activity, so you have to take into all pathologies into account. Also, counseling patients on therapeutic delays. This really has to do with neuro alterations. So there's always going to be some sort of compensation when we alter a really large neurotransmitter system. So there's going to be receptor uptake and receptor downtake. So you decrease receptor expression, increase it, and there's a fine-tuning effect with receptors being inserted into the membrane. And receptors are just proteins, and it takes about 3 weeks to make a new protein. So it's important that patients know there's going to be a delay because your brain is going to have some time to get used to this medication and make its fine-tuning of what receptors are available on what cells during this time. If you don't see an improvement with the medications, what is interesting is as soon as these are given, they have an immediate effect. Meaning if you test the plasma levels of the individual or human or animal, when the medication is given, there'll be an immediate change in their levels in the plasma of their neurotransmitters. But you don't see therapeutic effects until later because you need to have the compensatory effects of the brain. So if there's no improvement, check the dosing. There's a big dosing window on a lot of these meds so that you can perhaps escalate them or switch to another class. There's also a lot of adjuvant therapies. So that is when you add another medication to the regimen to increase the effectiveness of something that could be working, but perhaps needs an adjuvant to work in a more synergistic way for that patient. Okay, the next lecture I'll go through the specific medications, but that was my etiology talk about depression, and I will be back with our pharmacotherapies. All right, everybody, enjoy.